Good morning, everyone. Apology again. Today I'm going to present it's Mrs. 38-year-old female presented to my room with chronic cough, productive with blood-stained mucus. The cough was progressive in nature and associated with the shortness of breath, and there was no associated night sweats, loss of weight, or no chest pain. The past medical history is significant for diagnosis of pulmonary tuberculosis on the open lung biopsy in November 2023. And she was put on the anti-tuberculosis treatment and completed treatment about 5 months earlier. See, according to the patient, presented to a physician, specialized physician at the local hospital, who repaired her then to cardiothoracic surgery for lung biopsy because the sputum times 3 was negative. This was a CT scan done after lobectomy in 2024. And if you look on the CT scan on the right upper lobe of the lung, there's a nodule up there, and there's opacity also on the above the fissure on the right upper lobe also. And then on the left side, you see a very big cavity with some areas with the nodules below it, and of course with some areas of habitating nodules. And below the left lower lobes, you can also see absent lung marking. And the patient had, we look at the lung histology. The histology, of course, consists of 2 tissues. One was the mediastinal lymph nodes, and the other one was really the left upper lobe. The mediastinal lymph node comes as reactive follicular hyperplasia with sinus histiocytosis, while the left upper lobes show necrotizing granulomatosis inflammation with cavity formation with surrounding fibrosis, organizing pneumonia, and bronchiectasis. And there was no specific microorganism identified on the special staining, and the MCS was also negative for TB culture. The blood test, of course, which I performed, that was after seeing the patients, come as a P-ANCA positive with a high titer of 25. And of course, we did a nasal biopsy on the patient, which was normal, and also reviewed the histology, and the histology, of course, confirmed necrotizing granulomatosis disease. The questions: what's the differential diagnosis of necrotizing granulomatosis disease? Of course, they come in different forms. You can have autoimmune disease, such as GPA can give you that, Sachs-Strauss, and then infections such as tuberculosis, cat scratching disease, syphilis, and leprosy, not forgetting fungal disease also can give you exactly the same necrotizing granulomas. Idiopathic conditions such as sarcoidosis and hereditary conditions such as chronic granulomatous disease. Other diseases with secondary granulomatous manifestation would be like relapse with polychondritis, Langerhans cell histiocytosis, which is smoking related, and lupus. But also rheumatoid arthritis can also mimic exactly what looks like TB. But of course, when you're in South Africa, the prevalence of TB is quite very high in sub-Saharan Africa, and it makes sense that the patient was actually put on the TB treatment, but though more other tests could have been done. So today, my discussion really to look at the approach to pulmonary complications, pulmonary vasculitis, including its complications, what we call ANCA-associated vasculitis. The objective of the study is to look at the 3 things. One is to spot the respiratory complications of different systemic vasculitis. 2, to understand systemic and pulmonary manifestation of ANCA-associated vasculitis. 3, to develop understanding in the management of ANCA-associated vasculitis, especially the treatment of pulmonary complications. Vasculitis, when you look at vasculitis, we normally link them to the vessel size, and the kind of, you look at the vessel, iliac arteries, and then you look at the small vessels, and of course, not forgetting the capillaries and the venules. And if you look at the large vessel vasculitis, normally we talk about really the giant cell arthritis and also Takayasu arthritis. Medium vessel vasculitis, we do talk about the polyarthritis nodosa and also Kawasaki disease. And then ANCA-associated vasculitis means they can involve your medium vessels to your small vessels up to venous, up to veins, actually. And there are three really types. One of them is macroscopic polyangiitis, MPA, and then, of course, granulomatosis with polyangiitis, known as GPA, or previously known as Beckner's. And then eosinophilic granulomatosis with polyangiitis, previously known as Sachs-Strauss. And of course, not forgetting that this immune complex small vessel vasculitis that are also known to cause also vasculitis, and those would be a cryoglobulinemia vasculitis, which have got a strong link to hepatitis C and IgA vasculitis, previously known as Enoch-Sondler syndromes, and then hypocomplementary enteric vasculitis, or what previously known as anti-C1q vasculitis. Just quick summary of the giant cell arthritis. Giant cell arthritis, also known as cranial arthritis or also temporal arthritis. Most common of the systemic vasculitis, classic systemic rheumatoid disease of all. That's what previously known also. It come really with a lot of different names. But the most important thing that it never almost occurs in individuals younger than 50 years of age. They tend to peak in incidence in 7 decades, involve the large to medium-sized arthritis, and rarely pulmonary involvement. And if there's pulmonary involvement, those would be in terms of the pulmonary nodules and infiltrate with symptoms of cough. And then, of course, the diagnosis normally confirmed by temporal artery biopsy. And normally we don't see them, we see them mostly in the case, most of the patients present to neurologists or rheumatologists. Takayasu arthritis is quite very good for normally if you have case, normally tend to be put on the final year exams for students. And it's also known what we call pulseless disease. Uncommon chronic vasculitis unknown etiology primarily affects the aorta and its primary branches. The pathogenesis of Takayasu is poorly understood. Young females tend to be the really that are normally involved with these conditions. And then they will have pulmonary artery aneurysm, pulmonary artery stenosis, and pulmonary infarction. Diagnosis really is based on the high index suspicions. Patients tend to present with hypertension, diminished or absent pulses, or arterial bruise. Polyarthritis nodosa, and this is a really systemic necrotizing vasculitis, and the other three nodes. If they got they have no anchors, no glomerulonephritis, and no pulmonary capillarities. And if the lungs involved, it's probably not a PAN. Okay, bronchial artery involvement is being described in some cases. The kidney, skin, joint, and muscles, nerves, and gastrointestinal tracts are commonly involved. Idiopathic, although drugs, hepatitis B virus infection, hepatitis C virus infections, and hairy cell leukemias are important in the pathogenesis of some of the cases. And diagnosis based on biopsy. And if you don't have suitable area of biopsy, you can do imagings, and then you look at which will be your CT angiographics sometimes, which reveal microaneurysms of the blood vessels in the renal, hepatic, or mesenteric circulations. So most of the common it's really males that present epigastric pain, and most of them with the testicular kind of pains. That's really giveaway. Behçet disease, which is, we've seen that part in the context of when you rotate rheumatology, they tend to present with a lot of oral ulcers, and also in any of the systemic manifestations include also genital ulcers, ocular disease, skin lesion, gastrointestinal involvement, neurological disease, vascular disease, or arthritis. And in terms of the lungs, they present with what we call pulmonary artery aneurysms. And most of the Behçet cases sometimes are mistaken for STIs. Take note, please. ANCA-associated vasculitis, obviously, there are really two kinds of anchors, the P anchors and then the C anchors. And most people tend to get confused about actually, P anchors, because when they talk about P anchors, they talk is really the C anchors, and then the C anchors, they call it P anchors. So I really put this for people to understand. When you have anti-MPO, means that's more P anchors, and it's really more that related to perioxidasis. While your anti-PR3, that fall into your C anchors. And if you do an immunofluorescence, that's how you see it on the immunofluorescence or a laser. Just some bit notes about ANCA-associated vasculitis. It's very important to have right pairing as a high specificity and positive predicted value for ANCA-associated vasculitis. It's also ANCA testing performed indiscriminately in low pretest probability situation and can cause false positive results, especially the p-ANCA. Correlation of serious ANCA level determination with disease activity is unreliable, so you can use and really determine disease activities. And further predicted value of ANCA level increase for relapse is low. Treatment decision should not be based on ANCA levels alone, because you have seen quite a lot of patients that you find out their ANCA levels, but I mean, there's no clinical symptoms suggest that there's an active disease. So ANCA-associated vasculitis, of course, is a systemic necrotizing small vessels vasculitis, more common in adults and in Caucasians. No major gender difference, though microscopic cholangitis incidents are increasing in women, and frequency occurs of ANCAs is 82 to 94%, but not required for diagnosis because 10% of the cases can be ANCA negative, though thought to be pathogenic, so it can modulate the disease phenotype. So there's a significant overlap between granulomatous cholangitis and also macroscopic cholangitis. So our patients having MPA, not GPA. So more consistent difference based on ANCA type rather than the clinical phenotypes. So the comparison of the epidemiological and clinical features, if you look at the two, what we call the C ANCAs or PR3, which is more really found on the vecnous granulomatosis, and then P ANCA or what we call MPO plus, that tend to be on MPA. So the age at onset between 45 to 55 years, while in the MPA tend to be between 60 to 65 years. But I must warn you that our patient was 38 years old and she got the p-ANCA positive vasculitis. So patients are not textbook. The race or geographical, the North Europeans and Americans in the vecnous, but we've seen quite a lot in Africans. Asia and Southern Europe are more for MPA. Genetic difference, of course, there's really the involvement of MPA, major histocompatible complex with the HLA DPA1, while the other in the MPA is HLA DQA2, which are more really involvement. The risk factors for the vecnous will be your staph aureus, half-bound antitrypsin deficiency, and then celiac disease. Though we have seen them in the anti-hypertrypsin deficiency, but then tend to present more with epithematous changes than actually granulomatous changes per se. While drugs in the MPA, those would be things like hydrolysine, which we use common as an antihypertensive in pregnancy, that we tend to use also. Clinical phenotypes, of course, we say 80 to 90% in GPA, and granulomatous inflammation more common, while in the p-ANCAs tend to be 80-90% on MPA. But again, as I mentioned, there's a significant overlap between the two. Organ-specific characteristics, of course, with the GPA, that's why we did the nasal biopsy. There tends to be more ENT involvement, means the nasal and nasal septums, upper airways, pulmonary nodules. While with MPA, they tend to present pulmonary fibrosis, bronchiectasis, and renal disease, more severe and more chronic. Let's look at the new classification criteria for GPA, which was released in 2022. And this new classification, they look at the two aspects. They look at the clinical and laboratory data. The clinical, really, they look at nasal involvement with a bloody discharge, ulcers, crusting, and congestion, blockage or septal defect or perforations. And if you have the above, you can score them 3. While and also cartilaginous involvement, such as inflammation of the ear, nose, cartilage, hoarse voice or stridors, endobronchial involvement or subtle nose deformity. You can score them 2, and conductive or sensorineural hearing loss, you score them 1. In laboratory, imaging and biopsy criteria, so what you do, you take actually you look at quite a few things. One is the positive test for anchor. If there is positive PR3 or what you call the C anchor, you score them 5. And then pulmonary nodules, mass or cavitation on chest imaging, you score them 2. Granuloma, extravascular granulomatous inflammation or giant cells on the biopsy, you score them 2. And then inflammation, consolidation, infusion of the nasal or paranasal sinus, you give them +1. PANS, immune granulonephritis on biopsy, you score them 1. And then what you do, you basically that if the patient got a eosinophilia, you -4. So then you take the sum of the score for 10 items. If present, a score of 5 is needed for classification of granulomatosis with cholangitis. So our patient almost having more than 5. So the MPA need classifications, of course, also look at the score. Here, clinically, you look at nasal involvement, blood discharge, ulcer crushing, congestion, blockage, or septal defect of preparation 3. So again, you can't really look at the nose and say it's that and that, You kind of have to really understand it. It can be difficult to make a really diagnosis. Laboratory imaging and biopsy criteria, of course, in MPA, you look at positive test for anchor, that the patient gets +6, as provided they got a P anchor. And then fibrosis or interstitial lung disease, they get 3 score. And then granulonephritis on the biopsy gets 3. And if they're anchor, what you call the C anchor positive, -1. And if they go to eosinophilia, -4. The nodules and masses in GPA, of course, you can see that they have this sort of nodule on the right side with a big cavity on, or you can also see what look like masses. In most cases, patients sometimes can be told that they got a cancer, and so they really need to biopsy for you to confirm the diagnosis. And this is our patient. Again, if you look at our patient, you do have the nodule up there, and then also got this what we call cavitatory nodule. And after the patient underwent treatment, you could see immediately respond quite very well. The nodule becomes smaller, and then the cavitatory nodule almost disappear on the left side. And also, of course, especially with GPA, they can also present with subglottic inflammation and stenosis. And if you look there, you can look at the endotracheal stenosis there. And after healing, they can develop this complete stenosis. You can see the airway complete can be so narrow, and you see them frequently that you can pick up on the lung function test. And some cases of MPA, GPA can present with severe small vessel vasculitis and capillaritis, and they can present with what we look here as a crazy paving type. Means it's more like pulmonary hemorrhage, and and most of these patients really can have life-threatening disease, and with a high risk of mortality if they don't really get help very quickly. So what are the therapeutic strategies for patient associated vasculitis? Now the diagnosis is really based on multidisciplinary, the treatment based on multidisciplinary approach, and then the therapy has to be individualized. The most important thing, you need to decide whether the patient got a non-severe disease, means limited to one organs, or what we call non-life or organ-threatening disease, or the patient has severe disease generalized with life or organ-threatening disease. And really, we base the treatment on that. And the aim of treatment based on really 3 pillars. One is the remission induction therapy. Second is remission maintenance therapy. And third is prevention of drug toxicity and the side effects of the medications. And then, of course, you need to make sure those patients get immunizations and make sure they prevent pneumocystis jirovecii infection by giving prophylaxis. And in terms of if you're going to be using rituximab, make sure that you screen this patient for TB. They must have a TB spot and have a clean skin test, especially in countries like Americans, where most of these patients actually don't get BCGs. Those patients, because America don't vaccinate for TB. In South Africa, we vaccinate for TB. So you must really look at that. You should be able to read between the line. And if somebody got what we call latent TB, then you might need to put them on the actual TB prophylaxis before you start actively treating these patients. And obviously, you need to give them prophylaxis for osteoporosis because the many treatment is steroids, and you don't want to give them high dose of this. I mean, between the age of 6 and 8 years old, you treat them for the vasculitis, and then they get bone fractures. That also increase mortality. So prophylaxis for osteoporosis indicated, and of course, lastly, you need to monitor for hypogammaglobulinemia. If they're given rituximab, especially when they present critical care with the opportunity infection, then you kind of need to give them immunoglobulin to improve their immune functions. So the treatment, this is really based on the GPA MPA remission induction 2021. And that they really looked at for active severe GPA or MPA, means patient really with a life-threatening or organ-threatening disease. The recommendation is really quite straightforward: rituximab over cyclophosphamide. In the past, we have used cyclophosphamide for high-dose steroid, but now that's no longer the case. It's now more rituximab over cyclophosphamide. But if you're living in the third world countries where you've got no access to rituximab, or you're in the government sector where probably they cannot afford rituximab, then cyclophosphamide plus steroid can be used on those patients. And then, of course, and then you start them with high-dose glucocorticosteroid, and you obviously reduce them over time. Okay. And once the patient has entered remissions, you ask yourself if the patient is in remission. If yes, of course, the recommended remission maintenance therapy in order of preference, rituximab is still prepared over the cyclophosphamide, and then followed by methotrexate or azapres, and then MMF or leuconamide, which can be used. However, if the patient is not on remissions, we do recommend switching to different remission induction agents. In this case, rituximab or cyclophosphamide again over combining remission induction agents. So you get quite well, you can repeat your treatment again. And we've seen quite a lot of cases where most of the patient vasculitis, they've been subjected for plasma exchange for severe pulmonary hemorrhage. The question that, unfortunately, that there has been no randomized controlled trials to actually support the use of the plasma exchange in treatment of the pulmonary hemorrhage or the life-threatening disease or in vasculitis. So, and based on the guidelines, ACC guidelines, they said in patients with GPA or MPA with active glomerulonephritis, we condition recommend against the routine addition of plasma exchange to remission induction therapy. Okay, so in the past, all the nephrologists would tell you we give it. And in patients with active severe GPA, MPA with alveolar hemorrhage, we condition recommend against adding plasma exchange to remission induction therapy. Basically, what it's saying that it's really plasma exchange, there's no roles, and it does not support use of it, and does not add difference. But the question that when do we consider plasma exchange? Only when the patient has double positivity with ANCA and anti-GBM, which will become in my part 2 presentations. And also patients who are on high risk of end-stage renal disease, there's indication for that. And then also salvage or rescue therapy if all else has failed. And then this new kids on blocks, which is the roles of 5A receptor inhibitor, what's called ABO, happen in ANCA-associated vasculitis. And this was an article really published on the New England Journal of Medicine and review the use of that in patients with vasculitis as in the placement of high-dose glucocorticoid treatment of vasculitis. So the reference is really up to date, chest physician. So my next discussion will talk about EGPA vasculitis, and then we'll talk about immune complex vasculitis. Thank you.
Thank you very much. That was a very good presentation. If I may ask a question, you've touched on this, but just if you could highlight how do these patients actually present usually?
The issue that the problem with vasculitis,
I know it's complicated.
Yeah, it's very complicated. So they could present with quite from asymptomatic to symptomatic. They can present with really vasculitic rash in their legs, which you most time can be mistaken for thrombocytopenia or bleeding disorder, or they can present with just chronic cough in the cases of this lady with the bloody sputum, or they can actually present with generalized adenopathy also, or they can also present with just like chest pain or pneumothorax because of the nodules that actually ruptured. And some people, they can have continuous symptoms of night sweat, fever, also like TB. And then they can also present really by upper airway problems like congested nostrils completely. That they will go from ENT to ANC, they don't improve. Some people can present with a neural problem with what we call monoplex neuropathy, can present with that. Some can present with chest pain, they can present with even cardiac. So the presence is really non-perceptive. That's why I really couldn't really go into more details about that. But you have to have really high index suspicions, obviously. What the first thing, I mean, if you're in South Africa, you look at the prevalence of the vasculitis, of the condition of necrotizing granulomatosis. In that case, you really have to think about TB. Sputum for TB have to be the first thing. Make sure that you exclude TB. But obviously, the patient may not, if they're sputum negative, there's nothing preventing you to start the patient with the smear negative protocol for TB. But then at least you must refer the patient to a second opinion, to pulmonologists or specialized physician who have inside knowledge to the understanding vascular to make sure that, I mean, ANCA is not an expensive test. You could just do a screening test in patient actually that suspect with a smear negative TB. You really have to do an ANCA test and do AC and make sure you exclude the common conditions. But obviously, it depends where you are and what occupation of the patients and the exposures, and those play key roles.
Thank you. Is there anybody else with a question? Maybe somebody online?
That's all online. Yes.
Online guest.
Yeah.
Yeah. No.
Yeah, too.
Nothing else?
Yes. So thank you, guys. I think we'll do part 2 in the next presentations.